All right. So today we're joined by Dr. Chandi Chandrasena. And she's OntarioMD's Chief Medical Officer, providing the clinical perspective to inform digital health products and services for doctors. Dr. Chandrasena was an OntarioMD peer leader for 6 years, mentoring her colleagues on implementing technology into workflows. And she's held various roles at the Ontario Medical Association as a former District 8 chair and a member of several boards and executive committees. Dr. Chandrasena has specialized in family medicine for over 20 years and understands the challenges of community practice. She graduated from the University of Ottawa Medicine and completed her residency with the Northern Ontario School of Medicine. And then now she's developed a special interest in physician leadership and professional accountability and is a strong advocate for the family medicine community. She's been involved in and spoken at numerous national and provincial conferences, webinars, and given talks on digital technology, burnout, medical apps, and administrative burden. Dr. Chandrasena has also been the MC for the Canadian Women in Medicine Conference for the last 6 years and is looking forward to doing again so this year in Halifax, May 2024. Dr. Chandrasena, thank you so much for joining us today and giving us the opportunity to speak and learn from you.
Oh, thank you. Lovely to be here. And thank you so much for this opportunity.
So, could you give us a bit of an overview of Ontario MD? This is a very unique organization. There aren't really analogs to it across the other provinces. What do you guys focus on? What are you guys actually doing for the medical community in Ontario?
Yeah, so we're kind I like to think of it as the digital health arm of the Ontario Medical Association. And what we're looking at is getting digital health into the community. That's our focus, right? So way back when we wanted all physicians to switch from paper to EMR, there was a bit of a kind of impetus in every province to have that done, and funding was there also. And at that time, there were other counterparts similar to us. Over the years, the funding dried out, and so we no longer had our EMRs funded, and a lot of other provinces kind of shut down their versions, but Ontario kept it going. And so what really, we are a subsidiary of the Ontario Medical Association, but where we're different is that we're funded by Ontario Health. We're funded by the government to look at digital health technology and how we could use it in the community. So our mandate is really the community clinicians, specialists, family docs, but also their clinics, their staff, and any clinicians that are in their clinics themselves. So we have quite a big mandate. So I like to just say we're the digital health for the community.
And so it started out really focusing on that paper to EMR
Yeah.
transition. I mean, I would assume things are going pretty well down that department. How many clinics and doctors are still on paper charts then in the province?
Yeah, not a lot, I have to tell you. I think about the last time we looked at our numbers, about almost 90% of physicians in the province, in terms of the community, are on an EMR. So that transition is no longer where we focus on. So our focus now is more on, now that you've transitioned and you've been using it, some of us have been using it for 10 years, a little bit longer. Are you using it properly? Is there places we can tweak it? Is there places in your practice workflow we can help you with? Are you using the other digital add-ons? Have you kind of transitioned from using your EMR, just like a digital version of your paper chart, to actually using the functionality, and that it's really not a paper chart? There's so much more to it. So we've transitioned in our focus and also our education and where we're targeting.
So I love that. So one person actually put it to me like, you spend so many hours practicing with your, suturing pad, figuring out how
Yes.
to put stitches in. You
Yes.
spend so many hours practicing how to do different physical exam maneuvers. But when it comes to the EMR, a lot of doctors would just sort of like try and figure out the bare
Yeah.
minimum with it and just have that like basic level of competence to, as you put it, use it like a digital
Yeah.
version of a paper chart. And so what does the Ontario MD associate or organization, what do you guys typically work with the physicians in the community of like how
Yeah.
to use their technology better?
Yeah, so we have a very unique way of doing it. So we have a really robust change management and adoption division. So there's a number of divisions we have within Ontario MD. We have got a technology division that's responsible for certification of EMRs. So we're one of I think the only province that has a certification. So if you're an EMR vendor and you want to be in the community, you need to be certified. And so we manage that program. We also manage the vendor engagement program piece of it. So if there's things that we're advocating for that we want vendors to do, that's where that would be. If there's places where the province want the vendors to put a new functionality, that's where we would play. And so coupled with that is really the education piece and the change management piece that we're just talking about. So we have two ways of looking at it. One, we have staff, hired staff, that's part of our change management that go out, that are experts in EMR and experts in workflow. And there'll be a number of places that they touch. So they'll go clinic to clinic. So our staff live throughout the province. So if you're in Northern Ontario in a rural area, there's a staff member that understands your reality because they live there, they function there. If you're downtown Toronto or downtown Ottawa, you have staff that live and function there. And so that gives us an advantage in that we really understand what's happening in the local health system. And so we'll go to your clinic. We'll go to your clinic and we'll help your staff and we'll say, okay, here's a new digital tool you should use. We'll help you use it. We'll onboard it for the staff. So that's kind of what we do at OMD. We also have a really unique peer leader program. Our peer leader program, think of it as consultants. So we have about 60 odd consultants who are family doc specialists, office managers, or nurses. And they're that peer to peer. So, Jordan, when there's a doc telling you what to do, you're more likely to listen to it than when there's someone else telling you what to do, right?
Physicians trust physicians. That's just
This
how it
is
is.
it. Right. So if you have someone from an organization coming in and saying, okay, Chandi, you're doing this all wrong. You should use your EMR better. I've got all 1, 2, 3, and 4. Let's change it. I'll probably be like, you don't quite understand where I'm coming from. And you're right. I probably won't listen as much. But if you have another doc who's in your community, who uses the same EMR and who's kind of slogging away with you, telling you, hey, you're not doing this right, I can save you time, you're probably going to listen to them and be more likely to onboard it. So it's really that one-to-one, and that's why they're called peer leaders, because it's peer-to-peer. And so it's a combination of everything that really allows that change management to happen.
Very cool. I mean, there's just so many people vying for our attention and
I
for,
know.
trying to get our brains to pay attention to them,
I know.
whether it's a vendor, a service provider, a medical student, whoever, right? And so having something to help cut through that noise, and again, that peer
Yeah.
mentorship aspect of it, I think that probably goes a long way to helping with that.
It really does. And then we also offer conferences. So we have 2 digital health conferences this year. One's virtual in June. Anyone can sign up for that. And then we have one in person in September. Again, anyone can sign up for that, but less likely to come to Toronto if you're in Vancouver, whereas the virtual one you probably could. And what we focus is on tips and tricks. We focus on how to use your technology better. But we also focus on delegation. And that's really important because you don't have to do it yourself. You can delegate it to your staff. You could find a staff member who's like a super user and they could learn how to use the EMR or technology. And then they could in turn teach everyone else, right? It doesn't have to fall on our plate. We often feel like it has to be us and we just don't have time for it. And you're absolutely right what you were saying before. We don't give technology the attention it needs to have. Like when we talk about a medical illness or chronic disease, we're signing up for every conference possible. But when it comes to digital health, it's not really up there in the forefront. But if you knew what was out there and you knew how to use it better, it would actually make the clinical part a little bit easier. So it kind of goes hand in hand.
Why is that? Physicians are very skeptical with digital health, yet everyone seems very cognizant of
Yeah.
burnout running rampant and the admin burden and all these like problems. But why is everybody sort of pushing it to the back burner of that digital adoption?
You know what? I think there's when I look at our knowledge base and medical school and what we're teaching our learners, there's huge gaps. So one gap I would argue is practice management, how to run a practice in the community, how to bill efficiently, like what to use to actually make your life better and have that life balance. Like we don't get any of that. And then digital health is the other thing. You're kind of thrown into mostly a hospital when you're a learner. So you're learning these HIS systems or these hospital systems. In the community, if you're going into family medicine, it really depends who your preceptor is. And if your preceptor doesn't understand how to use the EMR, there's no way you're going to learn how to use the EMR, right? So I think it's kind of trickled down. Like we're just not putting a focus where we need to, which is probably in medical school onwards. And I think the other part is don't let people understand how we could help them. Because when technology came out, it wasn't like all the docs were on board. Yay, we need an EMR and we're part of the co-design and we've decided we want it. And then we work with the government to get it. It was more like top down. We've got these EMRs. Now we want everyone to use it. So whether you like it or not, here it is, go. And so you never really got that buy-in initially, right? And then as we progress, unless someone is really interested in the technology or if they've been inspired somehow as a learner or they had a preceptor that was amazing, they don't get that access. They don't see it. And I think that's part of the reason why change is so hard for us. Um, and really, I mean, we always hate talking about resources and funding but that's part of the problem, right? So when you're in the community, as opposed to being in a hospital or a community health center where you're salaried and there's lots of support and people to do this or help you with, in the community, all of us, we're kind of little mom and pop shops. And so for us to use our technology better, to onboard it, to put this in play, it's costing us money out of our pockets. And so it's not really a priority for us because we're just so busy actually getting these patients in through the door that it's not something we want to do, right? It's not something we feel we want to do. And I think that's a big barrier too.
How do you flip that around, I guess, right? Like where the incentives line up. Do
Yeah.
doctors every year, we got to get our CME credits. Does the
Yes.
Ontario MD, the annual
Yeah.
conference, I mean, does that
Yes.
help incentivize learning about and interacting with digital tech that way?
Yeah, it does. So I think the credits are important, but these one-on-ones that I was talking about where we come in and chat with you, those are accredited also. You can do
Cool.
self-learning credits for those,
Cool.
right? And a lot of those are QI credits. Like there's like a PDSA cycle. So in Ontario, our CPSO, they tap us every 5 years now to do a QI project. So
Hmm.
what I say is use this as your QI project. My QI project is I'm going to use my EMR better that I gain an hour extra a day or something like that. And you can actually use it for a couple of things. And I think it's about finding the needs. So the needs, right? So at OMD, and part of my job is to understand what are the needs of the community and then meeting those needs. So your need might be, I'm overwhelmed with my inbox, like completely knackered. I'm here like hours at the end of the day and I have to go through all these labs. And, these patients are calling me all the time and now they're texting me all the time. I can't handle all these messages. Okay. So there's a technology to help you with that, right? So then if that's your need and that's what you're going to put effort into, then it's kind of coming in and saying, well, we can set up some automatic templates in your EMR. We can help you with the toolbar. We can monitor your patient portal and we can kind of set up a couple of other things there. And so now you're using a technology to meet your need and you're going to learn a little bit more about it. And then you'll be like, hey, this actually helped. Let me look at this. And then you're kind of more open to learning, right? And I think you need to start with the needs first. And that's where the problem is we start with the education. You have to learn this. And here's 3 topics, right?
Hmm.
But think of medicine, right? Like, where do you go for a conference, right? You're not going to go to diabetes if you think you're like a superstar at treating diabetes. You're probably going to go to maybe the dermatology conference because all the rashes look the same to you because that's your need. So it's the same kind of thing. You have to approach it from a need perspective.
That's super interesting. I would have never thought like of QI in that context of like digital tech and workflow.
Yeah.
It's always how many of my patients are compliant with the latest screening guidelines or something very
Yeah.
clinical like that. But
Yeah.
so you can actually take it and make that into your annual project or
You
however your
absolutely can.
cycle is. Very cool. But what
Yeah.
about for those of us who aren't privileged enough to live in the center of the
I know.
universe where OMD happens to be located? Like, does any of the resources there, would that apply to the tech and the EMRs we're using out west or elsewhere?
Yeah. So the top 3 EMRs across the country are the same, right? So TELUS, Acuro, and Oscar. Well, so those are the top 3, regardless of which province you're looking at. So our conferences are open to anyone. So the tips that our OMD educates at lunchtime, where we talk about technology and functionality and privacy and security, it's open to everyone. Now, mind you, privacy and security is going to change depending on the province because you have different
Mhm.
regulations, but the general concepts are the same across the province. So there are opportunities at that point. If you want that one-on-one right now, it's really not available, like, because we're very Ontario based and that's how we're funded. But having said that, there's nothing to say that you can't advocate the same with your PTMA or your provincial organization, or even, so here we're starting to have our OHTs, our Ontario Health Teams. I know in BC, you've got your authorities. Other provinces have other areas. So there's nothing to stop clinicians or physicians going to one of those organizations and saying, why don't we set up something similar for this area? And there's nothing stopping us from coming and helping you set that up. But that one-on-one, we stay within Ontario.
How did you keep the funding for this going? Like initially it was for
Yeah,
EMRs. How did you convince Ontario Health to actually like keep this going? Because it sounds
I
like
know.
something that every province would benefit greatly from having.
Yeah. So I think, so that was before my time. I've only been in this position for 3 years. And as you know, the EMR funding dried up a long time ago. But I think it's pivoting. It's pivoting for the needs of our funders. So our funders was Ministry of Health, and now it's Ontario Health. And that's how our funding comes. So we're actually funded for their priorities. So initially was EMRs, but now that it's more digital tech related or privacy and security related or patient summary, interoperability, integrating, those are their priorities. And so a lot of those priorities require physician input and buy-in, and they require tools to work. And because we've developed this amazing program for change management and adoption and vendor management, it only makes sense that you would want to fund us to help you move your priorities. And that's ultimately what we're funded for. But because we have this change management and it requires education for onboarding, we're able to do all this also as part of that funding. Because if you don't do that, and I just come into your office and say, I've got this great tool for you, you're going to slam the door in my face because I'm not meeting your needs and we don't have that trust. And I think you need to build trust before you can come in and say, this is what's coming. And I have to say, we're pretty honest. Like our peer leaders, they're not staff, but they're docs and they're pretty honest. And when something doesn't work and they don't like what we have to onboard, they're going to tell us that. And they're going to give that
Yeah.
feedback and they're going to be like, there's no way I'm going to use it. So there's no way I'm going to tell someone else to use it. And I think that's really valuable feedback to go back to the funders to kind of say, how do we make this better?
What kind of digital tech, the non-EMR stuff
Yeah.
are you guys working on recently?
Yeah.
What does that actually look like?
Yeah, so there's a couple of things. So right now we're doing an AI scribe project. So I'm not sure if you've heard about that, and that seems to be like the new sexy tech that's on the horizon. Anything AI is going to solve all our problems, right?
Big fan
Uh,
personally of all these AI scribes. I think it's
I
a game
know
changer.
it's a game changer, but you know what? It's still a technology, and it still has to meet your needs, right? And it still has to solve your problems. And so right now, I'm going to back up. So when the EMRs came out, there was no regulation. It was just like, here's an EMR, and they're going to come to your office, and you're going to sign a contract, and you're going to take it. And there was no like, pick these EMRs. This EMR is better in the long term. These ones are going to integrate better. Like we didn't like hindsight is 2020. Is that what they say? So at the time it was just like go crazy, and I know BC has something like 20 EMRs or maybe 25 or 30. Ontario has 13 even with our certification and other, right? So it's kind of like it was kind of a wild west before we said, okay, hang on. And that's kind of the way I look at AI, right? So AI is kind of going direct to physicians and clinics, and they're saying, look at all the things we can do with your EMR and your data. And scribing is unbelievable. But we need to kind of rein that in a bit and say, well, hang on, let's look at the evaluation of it. So our project is to actually look at evaluation of AI scribe. So what do AI scribes, all of them need to have to be a functional, good product? Where are the gaps? What about that contract? What are we signing away without understanding it? Where should we look for, like, what should we ask about our data and our data governance? Like things that we're not really equipped to think of as docs in our clinics. So that's what this AI scribe project we're doing. And it should be wrapping up by midsummer Well, will have an evaluation and an approach to AI scribe at least. And then what we're hoping is then we can actually look at other AI as it becomes more available. Um, so that's the most exciting thing. Then we're kind of looking at our other stuff. So in Ontario, we have HRM, a hospital report manager, which is kind of sending reports that come through the hospital, bypasses the fax and goes directly into our EMR, right? Really? So you might be thinking, that's a great technology to have, right? You don't have to fax, it goes right into your EMR. But in retrospect, now we're realizing that's creating this huge burden, because before, when a discharge summary was 3 pages, now it's 15 pages. And it's all coming in because you can click anything and just send it. And now the receiving docs and clinicians are just overwhelmed. So a lot of what we're doing now is also looking at the technology that exists and seeing, okay, how can we make that better? How can we now backtrack that and make that better?
That's where that interoperability comes, I guess.
Yes. Yes.
Very cool. And so when it comes to like things like the EMR and the AI scribes, like it's super cool to actually see a central association paying attention to these, because a lot of the places, they're sort of hands off, right? Like,
Yeah.
ooh, vendors and service providers, icky, we got to remain neutral. How do you dive in and then sort of be that contact point and help people navigate those waters
Yeah.
while also still maintaining that vendor neutrality, or that arm's
Yeah.
length?
And I think that's because we have our certification that we're able to do that, right? So if you're going to be an EMR that we're going to talk about, you have to be certified. And so that certification piece kind of allows us to kind of be experts in those certified EMRs and to say, okay, for those that are on practice solutions, here it is. And we work very closely with vendors also, which is really good in the sense that there's a trust relationship there also. So mind you, it doesn't mean vendors do everything we want them to do. I mean, that doesn't happen. And doctors are still upset with their EMRs, regardless of which province you're in. I can say that. But it's just one step more than I think that other provinces have, right? So it's kind of that collaboration piece. And like I said, we're pretty honest. Our peer leaders are pretty honest. So when they do their talks, they're not always speaking on behalf of OntarioMD because it's more of an education piece. And they will say, I've tried 3 EMRs and this is why I like this one and why I don't like this one. And as long as I feel that that's a really important piece to be there, right? Like that's how you're going to learn from your peer and what they've tried. So we don't limit what happens in our education sessions because they're independent. Like we are just offering the platforms, we offer the topics, but the speakers aren't always OMD speakers. And I think that's why it comes across as being a bit more balanced at times.
What actually goes into that certification process? Is there some criteria or standards
Yeah.
that need to be met, or is it more
Yeah.
like whoever and whatever it is, but you guys internally getting comfortable using it to say that, okay, we now understand this tech fully?
Yeah. So I think it's a bit of both, but no, there's discrete certification standards. It's on our webpage. And some of them are functional standards, but most of them are technical standards.
Hmm.
So they're probably things that as docs, we don't even realize are important or care that they're important, but at least you know that if you get an EMR, they're there. Things like, this you would care about, like you have to have like a medication module, right? For prescribing, you have to have a billing module. Because not all EMRs have that, right? Or didn't have that in the beginning. You have to be able to migrate the data in and migrate the data out, right? I mean, it's not perfect. There's still trouble leaving an EMR, but at least our certification is the minimum standard. So what it is like, here's the minimum you have to meet. And then what extra you put on top is your book of business. That's why someone would pick vendor A over vendor B, is because they've met the minimum, but look at all this other amazing stuff they could do, right? So we're about kind of protecting the minimum based on our standards and criteria. And then the rest is really up to what you choose as a doc in your clinic.
How much goes into looking at like the privacy or the security
A
aspects
lot.
behind these technologies?
Yeah, a lot. So a big chunk of the certification is the privacy and security. And it's not just a one-time okay, it was good today. This is an ongoing thing. So they have to prove that ongoing as they want, if they want to stay certified. So they could lose certification if they're not able to meet these requirements. And the requirements do change slightly depending on what our regulate, like certification is kind of based a little bit on regulations too. So they'll adapt and change. So we've had some vendors say, no, we can't keep up. So then they become decertified. And what that means is if you don't have certification, then yes, you're not one of the certified vendors, but then you also lose access to the provincial assets. And that's why it's really important to be certified, because they don't want any EMR touching their provincial assets. That's not secure privacy wise, because that's the most important thing to them.
Yeah.
And then everything else kind of falls in place.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, nurses, chiropractors, and all other healthcare professionals can sign up for free, start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across Canada. With dozens of healthcare specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum with hundreds of new jobs posted every week. www.cherry.health to get connected today. And then, can you speak a little bit more about the AI project that's ongoing? Because, again, such a fascinating area of tech with a lot of potential and promise. What are you guys actually doing to like help bring those to the forefront safely?
Yeah, so right now with AI Scribe, we're looking at it from, like I said, from an evaluation point of view. So what I'm hoping is at the end, we already have a lot of lessons learned, and a lot of it is around that privacy and security, that data governance, like who owns the data, where does your transcriptions go, the recordings, that kind of piece. And I think at the end of it, what it's going to happen is, what we're hoping is we'll be able to identify the gaps and kind of say, this is where and you need to fit, like to meet it. So this is version 1, but version 2, you need to be able to do A, B, and C. And then could we develop a certification in quotes, because it's not a true certification, for AI, where there's a minimum piece that you need to meet in terms of privacy, security, what your contracts look like. And it's really kind of giving that sense of security to clinicians, to know that if they pick one that's been certified or looked at or vetted, whatever you want to call it, that the minimum's been done for them, right? We're also looking at scaling and spreading, because there's a lot of need for documentation in AI Scribe, right? Like it really does move the needle on administrative burden.
Oh,
So
hugely.
because we were like, it's amazing, right? And because we work so closely with the ministry, like if we finish these projects and we look at all like what's out there and we do an evaluation and we understand what's happening, that gives us some really good data and some kind of advocacy piece to say, listen, what if you funded AI for everyone in the province, right? What if there's one AI that could be the AI of the province, that we're able to fill in the gaps and kind of shape the way that they're going to become and meet our needs, instead of us having to decide what to buy from vendors who are meeting their needs, right? So obviously I'm generalizing, because there's a lot of great products out there, but it's just kind of, it's the idea of who's in control of the technology. Like, is it the technology that's changing us, or should we be in control of the technology so they're meeting our needs and helping us where we need it to go? And right now, there's no one, I mean, it's not like we can control AI because it's already out of the barn, but there's no one like even the like regulating it or understanding it or kind of looking at the pitfalls, so that 5 years from now I'm not on your podcast telling you how AI has created such a burden and how my data is everywhere and now I'm liable for it and how these breaches are happening. Like, we're trying to kind of get in front of that right now.
And so earlier you mentioned that part of OMD's mandate is, the certifications and the education, but you're also acting more as like the advocacy body
Yeah,
interfacing the physicians with the technology.
yeah,
How do you foresee that going then in terms of like the AI versus the EMR vendors? What kind of
yeah,
direction would you like to see them take it, either from the functionality or the security or the
yeah.
operations of it?
Well, I think the issue is our certification is a very tech privacy heavy certification. It's not a functionality like number of clicks or ease of use. It's not. what we call a usable type of certification, right? So I think part of our advocacy is understanding, can we make those changes and those improvements? And that's where I hope that we'll be able to do in the future is like, okay, you've met the basics in terms of privacy and security, but why does it take me 20 clicks and 3 pop-ups to do a prescription? Could we start having some sort of rules around that? And that's what we're looking at. So in Ontario, we're also looking at what we're calling a managed health digital service, where I like to think of it as kind of a value reseller of EMR technology or technology in general, or in my brain, I think of it as a broker, right? So if you've got like in your clinic, let's say you've got 7 docs. So you go to the EMR vendor and you go, I've got 7 docs. What's the price you can give me? And how much is your AI? And can you throw in a patient portal? And you're negotiating. It's like buying a used car.
Hmm.
Everyone's negotiating individually, and some people are really good at it and some people aren't. And some people are solo, so they're not going to get as good a price if you're 20 docs. And it's all over the place, right? So what we're looking at in Ontario is, could we become that voice or that broker or that like kind of that managed digital service for EMRs and technology, to the point where we could say we've got like 2 or 3 OHTs that are interested in vendor A. So vendor A, this is what they want. This is the price they want to pay. I'm making this part up because we're still kind of looking at it, but they also want AI scribe thrown in, and they want A, B, and C done in terms of functionality. Are you able to meet this? And so it's now we have a bit more of a voice, right? And could you imagine if this came en masse with all the docs in the community? Because now you can make those changes with the vendors that right now we can't really do. And so that's the other kind of big project that we're looking at, kind of saying, how do we make this work? OHTs, because that's kind of how Ontario is starting to be divided, are already talking about that, like, in terms of anything, like, is it IT, like computers for your clinic, for IT services for your clinic, privacy and security, like cybersecurity? Could we do it en masse? So OntarioMD is saying, yeah, we could do that. We can help you do that. And we're just trying to figure out what that would look like.
I think that makes total sense, right? Just that bargaining, negotiating power
Yeah.
that comes from working as a group together. How do you manage the heterogeneity of it though then? Because like everybody's got a different
Yeah.
EMR, everybody wants to use a different
Yeah.
tool, everybody wants a
Yeah.
EMR with the different modules added
I
onto it.
know.
How do you effectively actually take that to the bargaining table?
Yeah. So I think that's why I'm saying we're in early stages, because you're absolutely right. You put 5 doctors in a room and they want 5 different things, right? But if you put 5 doctors in a room who want 5 different things, and you've got the skills to figure out what's most important to them because they're actually going to see some benefit, maybe the 3 things that were the outlier is no longer important, right? So maybe we can start kind of bringing people together to say, this is what we want for this area. And these are the top 5 things, and everything else is just a nice to have. And could we find that nice to have in some other sort, in terms of like like a workaround, or could we use the functionality of the EMR to help you get those nice to haves, right? But what we want the vendor to do should be big picture things that actually move the needle on burden or cost, or just makes it easier for us, right? So I think I think when that I think when you kind of hold out that I don't know what the word is, but when you hold out to say there is a chance that you could actually more control over the bigger pieces and possibly save yourself some money, I think people will start to align a little bit better.
Yeah, just getting a consensus and definition around what is
Yes,
that base model package and how can we
exactly.
negotiate that for the group?
Exactly. So the community health centers, or the CHCs in Ontario, have been doing this for a while. So they've actually, so we're kind of looking at the model that they've done, where they have done this with a single vendor, saying everyone's going to be on the same EMR, and here's the functionality, and we want a discount, we want all these things done, and it's worked. Like, that's exactly what they've gotten. So it's doable. It might come with the expense that you might not get every little thing you want in your EMR, but then I think that's where you need an organization that knows how the workflow is, and maybe what you want in your EMR isn't actually that efficient. Like, maybe then it's stepping back saying, well, instead of wanting this, maybe what you really need is this technology at the front end so that you don't even have to do that. Like, obviously I'm kind of being very general, but that's how we would want to look at it.
Very cool. And then where do you see the AI powered tech going? Right
Yeah,
now it's very much in the scribe
it
world
is.
and making the
Yeah.
chart notes. What do you think is going to be the
Yeah.
next generation after that?
Oh my gosh, it's going to explode. Right now, AI Scribe is probably the most mature, because it doesn't require true integration into your EMR, right?
Mhm.
Because it's a standalone, it could be web based. It's a mic. It's just a mic with I mean, not just a mic, but it's a mic with a transcription with algorithms and then the AI behind it, right? Um, and it doesn't necessarily is integrated, so you don't necessarily have to work with the vendors. You could do it independently. And sometimes docs don't want it integrated, right? They don't want to have that huge transcription in their EMR directly or the recording, because now you might have opened yourself up to liability on every word that's in there. Like, you probably want it separate, and then you can adjust your note and paste it in. And I think that's why AI Scribe has taken off, and it's kind of a low hanging fruit from that point of view.
Mhm.
But where we need is, I think the next step is going to be around AI assistance, like the inbox management, I think is the next spot that's going to be. But that requires more integration into your EMR and understanding the reports coming in. And there's more functionality. Then there's like the point, like the clinical decision tools, right? Like, you're sitting there, and wouldn't it be lovely if you're sitting there, you see your patient with diabetes and heart disease, and you have an AI that's putting all this data into all the randomized controlled trials out there, and then it spits out, according to the top 3 trials, you should be considering drug A, B, and C. And you haven't actually ordered 3 of these tests that you should order now. Like, that's what I would want my EMR to do, right? And kind of like the up to date in an AI version, but doing this panel analysis for me. And that's coming. So there are a few AI products out there that are actually doing that right now. So I think that's going to be big. And then the other part is AI patient management, like the triaging before they even come see you, getting the information you need, like making sure your notes are like up to date. And then the post management of patients, remote patient monitoring, the wearables, the apps. Like, there's so much that we can do with patients that will then take that off our plate, because they can manage that on their own with AI. And then we can just come in when we need to. Like, now you're getting me all geeky excited, because now I'm thinking about the technology piece of things. Um, but we have to be careful that we don't fragment it, right? Like, so I'm paying like vendor A for AI Scribe, and now I'm paying vendor B for like inbox management. I'm paying vendor C for like, it's too much, and it's gonna be very expensive for us. So I think someone needs to kind of bring it all together into one kind of roadmap and kind of say, where can this go? And I think that's what our EMR vendors are probably working on, is how do I bring it all together so I can raise the prices here, but keep this going.
Do you envision this becoming more in-house, the AI and the patient decision-making tools and those clinical
Yeah.
supports and the workflow automation? Do you think that's going to start to land in that ballpark of the EMRs? Like, because it's going to be
Yeah.
very difficult, again, with the heterogeneity of the different
Yeah.
EMRs for these AI companies to integrate. Like,
Yeah.
for a market as small as Canada, that's going to be a challenging
Yeah.
trade-off. Do you think the EMRs are going to start doing it all in-house? Or I guess, to put it another way, in the States, do you know if this is all already happening within a single EMR because they just have the power to do so?
Yeah. So I think the States is a very different beast. So it is happening in their HIS systems, right? So Epic, Cerner, Meditech. So a lot of this is already happening in the States in terms of Epic, and it's starting here also for the hospitals. And in the States, it's the Epic modules that are traditionally in the community. Like this concept, I mean, not everywhere, but most places, this concept of having whatever EMR you want and having so many to choose from in the community that doesn't talk to the hospital, doesn't talk to each other, that's very much a Canadian problem, or other countries too, but that's a Canadian problem, right? So I do think in the States it is happening, because the vendors it's tighter, it's smaller, and they have a whole different focus on where their resources and money go, right? Here, I think this is where we have to be careful, right? Because we want to be independent of the vendors, right? So that means the vendors need to open up their APIs, and so that companies can compete and innovate. Because right now, Canada, what I've heard from a lot of companies is that this is not an innovative market for them. Like, they build all this and then they can't get it into an EMR. And if it's not integrated into an EMR, then docs won't get it. And then if it costs too much, docs won't get it. So then they go to the States because that's where their market is. So I do think we need to look at ways that we can start kind of opening APIs from vendors, or is there a way that the government can step in? It has to happen from a regulation legislation point of view, because I don't think it's not going to happen with you and me, like our organizations or family docs or anyone saying it. I think it has to happen from a top down point of view. But if they're able to open that up and make it a lot easier to use these new innovations, then I think it doesn't matter if it's vendor dependent, because then you would just pick what works for you. Until that happens, though, right now, it is very much in-house. And I do think vendors are looking at, I mean, I think they would not be prudent if they weren't looking at this, right?
Hmm.
Like, there's a lot of work being done in that field.
Is anybody currently looking at that or advocating that, in terms of that just regulation standpoint? Because when you look at
Yeah,
it from, TELUS's perspective or
yeah,
whoever, they've got their walled garden. Why open it up? Why make it
yeah,
easier?
yeah. Well, I think part of it is it is their business. Like, like it is their business, right? But I think it's not that they don't want to open it up. Sometimes I think it's the technology doesn't talk to each other, right?
Hmm.
And they may not want to put that effort into it, or they're worried about their privacy and security, because when you open it up, now you're opening up all our PHI, our EMR, and all our data. Like,
There
so I
doesn't
think
seem to be a
there's,
lot of incentive for them to make those changes unless there was a regulation piece that came
yeah,
from the top.
yeah. I do think so. I think there's two sides to every story, but yes, I do think it has to be from a regulation point of view if we're truly going to start looking at innovation. I do think the kind of health info way is kind of the federal digital health arm, um, and Canadian Medical Association. I think these are conversations that they're having in terms of data out, right?
Hmm.
Like, how do we get data out of EMRs? How do we get EMRs talking to each other? How do we get coding and standards? So these conversations are happening. They're also happening in the provincial level, where they're saying, well, how do we do all this so that the vendors are able to do this in the background? So it doesn't put burden on physicians, but it doesn't put extra cost on physicians, but it becomes just, you have to do it. So those conversations are happening, but I think those conversations have to be decided at a much higher level than us.
It's tough, right? And I think that's a big part of why the AI scribes have become so popular, like almost overnight, it seems, right? Because
Yeah,
it's
it's
EMR
easy.
agnostic and you can use the tool
Yeah,
anywhere.
yeah, and it meets the need, right? Like,
Hugely, hugely.
our early studies are saying that you're saving 4 minutes per visit, and that's like an hour and a half, almost 2 hours by the end of the day, right? Like, it meets the need. Like, that's your biggest burnout point, and you've got this technology, like you said, it's not in the EMR. Anyone can use it, and it meets the need. I mean, it's not perfect. It doesn't meet everyone's need, but it meets a lot of the needs.
We're getting there. We're getting there.
We're
It's
getting there.
definitely like a very big, shiny beacon of hope amidst the burnout and
I
admin burden.
know. I know. Yeah, I've heard that from so many docs who have already started using it. They're just like, I was going to quit. I was going to quit, like, probably by the summer, but now I think I got a couple of more years in me. And that's really powerful when you have a tool that's actually going to extend your working for another 2, 3 years. So your patients still have a family doctor, which is why I think that scale and spread is so important, right? Like, it shouldn't be up to us in the community to be funding this so that we will stay there longer. Like, this should be something that's funded by government or outside of us, because it's actually helping the health system as a whole. And the cost is not insignificant, right? Like, it ranges, but it could be up to 250 a month, 300 a month. Like, that's a lot of money when we're paying, like, it's doubling our cost for the EMR, and it's only just one AI scribe. Like, what happens when it's AI inbox and everything else?
I think the DAX software from Nuance Microsoft, that one was like $600 a month, even for the Cadillac of AI scribes. It's crazy how much
Yeah,
extra, but I've never tried that one. Perhaps it's
no.
worth it and it's just such a
Oh,
smooth ride. I don't know.
for $600, you should like see all my patients and bring me a coffee while I sit in the back. Like, that's a lot of money
No
because
doubt.
you're also comparing it to like a physician assistant or a human scribe, right?
Yep.
One of our peer leaders who've done excellent work on human scribes and had developed a bit of a training program around it is kind of looking at AI scribes and human scribes because and physician assistants and using staff better and kind of making a mix of it because there's still stuff that the AI cannot do that if you just had a human next to you doing it, that would probably save you much more time, right? And effort and like so you don't want to jump on the AI bandwagon because you want to kind of step back and look at everything, which is why I kind of always say go back to your needs assessment, right? So I mean, digital health such a I don't know, people don't get excited about it, as you know, and no one wants to hear that you have to do something methodically. But basically, you need to look at your workflow, right? So you need to map it up. So this is my people get tired of hearing me saying this, but you need to get a giant piece of craft paper, some Sharpies and Post-its, and you just map up your workflow and you put it in the kitchen in your office. And if you've got staff that can help, they add in where things are bottlenecking, why it doesn't work for them. And then you kind of figure out where the solution is. So AI scribe might be the solution, but maybe you're someone who uses your EMR really well. You've got templates, you've got custom forms, you've got stamps, you already have developed some sort of algorithm. You use e-forms that you send out to patients that auto-populate. Maybe you don't need Scribe because your chart is already done, right? So maybe you don't need to jump on the Scribe bandwagon. Maybe what you do is you look for a technology that helps more on the front end of things, right? But you're not going to know that until you map it out, look at your needs, and then figure out what you need, right? In terms of the pros and the cons, and then picking the right technology.
Now, this is where the next QI project cycle comes into
It
play, like
is.
starting with that
It
exact
is.
framework, just
It
mapping it
is.
out the old fashioned way on a whiteboard with the rest of your team and just
Yes.
brainstorming over where's our bottlenecks.
Yes. Yeah, and people don't do that, right? People just kind of they don't. They just kind of look at it and go, "Okay, I'm just going to implement this tool." But it's like, is that the tool you need? And is it going to solve your problems, right? So in Ontario, you can do QI projects as a group also. So if you have 3 docs in your office that are all need to do QI projects at the same time, then this could be an office QI. You get a lot of CME for it. You can get your staff engaged. Like the biggest thing that we also forget about is our staff have to deal with our decisions, right? So if you're making their life hard, they're not going to be happy. So if they're engaged in this mapping and they're able to say, okay, I know you offloaded this to me, but look how much time I'm spending there. And there's this technology that can make my life easier and I'll be a happier staff, then maybe that's where you want to put your efforts, right? Like, and then they have buy-in because if they have buy-in, then they're more likely to be part of the solution. So I think there's a lot of pluses there. Like technology is just a tool. It's not going to save you. It's not going to be like the light at the end of the tunnel. It's just a tool. So just like your EMR is a tool, just like the other digital health stuff is a tool, it's kind of how you use it and if it actually helps you.
How do we start shifting that, vibe in terms of the physicians across the country, become an early
Yeah.
adopter or at least like
Yeah.
start getting excited looking into these things as opposed to like, oh, this just seems like another task,
Yeah.
another unpaid chore. Because I
Yeah.
mean, I think there's a lot of potential there to start putting some light at that end of the tunnel and giving
Yeah.
people more hope and freeing up their time. How do we genuinely change that culture in medicine?
Digital education in with the learners, um, digital onboarding. So if you're a new doc that's just graduated or a locum or a new doc to the country, then you should be like, here's all the tech that's out there, right? Because if you get them early before you start a practice and get kind of bogged down, you're more likely to make those changes and get excited about it. You need to find champions, right? Like, So in my clinic that I was in, there's 7 of us, and then there's 2 of us who are just more digitally inclined. And it's like, look at this cool thing that we discovered. Then the others are like, oh, can we use it? Right. So it's kind of like that infectious digital champion piece.
Yeah.
And so that could happen at a clinic level, or like I said, like a regional level. What if it's a community of practice, right? Like if you've got all these EMRs in your region, there's nothing stopping from someone starting a community of practice where you share this information, because that's how a lot of this started in Ontario and still goes on, right? So it's kind of like the small pieces there, right? Then the other pieces is getting investment from the government to do this, right? To advocate that change management and what we're talking about is really important, and then having funding to set up a program for that, right? We're just in the process of looking at e-coaching modules. So basically, it's kind of like choose your own adventure, right? You start with your module and then you go, okay, this is what I want to learn. And it opens up another module. And then, so you learn what you want to learn, right? And then someone else will go into that module and learn something else. But anyone can do it, and anyone can do it easily. So then you're not limited to signing up at 12 o'clock on this day to listen to a lecture, or, a one-on-one in your clinic. You could do it your own way. So stuff like that, I think it could be easily scoped to the entire country and scaled outwards, but you need a priority and you need funding and you need, like, it has to be done well. So if I had a pitch for Ontario MD, if you find me funding in any province, we'll come and do it for you. But it has to be a priority.
Where do you guys typically house all your not sorry? Where do you guys typically house all your knowledge? Do you have like an online forum or
Yeah,
community
we
that
do.
docs can like participate in?
Yeah, yeah. So we have, so if you go onto OntarioMD.ca, our website, you'll see our education piece. And if you go into OMD Educates, which is our education line, you'll see all the webinars we've done on lunch. So we're doing one tomorrow on secure messaging portals. We did one last month on AI Scribe. We had like over 800 registrants for a lunchtime webinar, right? They're CME accredited, right? Only for family doctors right now, but they're CME accredited. So you have access there. In terms of our conferences, like come see us in Toronto. But the virtual one in June might be an option, right? It's on June 12th, and it's also on our webpage. But that's a great one because you could do it from home and you could look at the tips and tricks, and there's recordings that you can have afterwards. You get all the recordings if you sign up for our conference. So that's a great one. The other educational pieces are really, they're not always recorded. That's the problem, right? They might be live pieces. But we're also available for other provinces, right? So if a province wants us to come and do a education piece for them, so maybe they don't want to invest in an entire program or a change management system or everything I'm talking about, but they just want to kind of talk about AI Scribe or something, then we could come and do a talk like that. Like we could do a smaller version of it. But it's kind of what works for you and how can we help you do it. But at the end of the day, it has to be a priority for your funders.
Yeah, yeah, that's the bottleneck for everything, it
That's,
seems.
yeah, that's it. Exactly.
And then how's the Canadian Women in Medicine conference going? Is there a big like digital or AI tech focus there?
It's not actually. So you know what? It's a huge conference. We have around 1,200 in-person attendees usually, and then plus the virtual. So we do have a virtual option too. And it's really about supporting female physicians, like women physicians. Anyone can join. I mean, I don't see any men joining, but any man can join. It's open to everyone. But it is geared towards women physicians. And the program is amazing because you leave feeling so supported. But the topics are not traditional medical topics, right? Like you're not learning about chronic disease or technology. I mean, one year I did a talk on medical apps, about medical apps for yourself for productivity or medical apps for your patients. But traditionally, it's not a digital platform. It's more of a supporting well-being. It's like a wellness conference. So a lot of our speakers are about leadership, about branding, about confidence, about negotiations, contracts. Like, it's stuff that you don't really learn in medicine per se.
A lot of the softer skills and balance and
Yes.
wellness focused. Very cool.
Yes, yes. And how to manage your family and in your life. Like, a lot of kind of hands-on kind of techniques and tricks and tips.
So, all right, so guys out there, it's a non-discriminatory event. Please
Come.
sign up. So tell me a little bit more, just back to OMD then. What is this digital hygiene initiative you guys are working on recently?
Yeah, so we do a lot of work on burnout. So when I joined 3 years ago, burnout was just starting, right? It's post COVID. We were really seeing the impact of it, and over the years, it's just gotten worse and worse. And really, everything that we do is a lens of a physician, but it's also the lens of burnout. And technology is a big part of that. So Ontario Medical Association actually did a white paper called Healing the Healers, where they looked at burnout from a health system point of view. And what they came up with is that this is not a me, you problem. This isn't me not working hard enough or me not using my EMR properly. This is a health system problem. That's where the solutions need to come. And so they focused on 2 digital pieces. They had 5 recommendations. And one of the first digital pieces was interoperability and integration, right? Like, don't give me different portals with different passwords that I have to manage. And then the other one is decreasing that administrative burden. Like, we need technology that just kind of tackles that documentation piece, right? So that's where AI Scribe and everything comes in. So along with all the work that I did with them, and then so many talks that I get to go to, that I'm privileged to go to, where I hear other leaders in burnout talking about burnout and their lens and their ideas and their research, um, kind of helps you shape what you're in turn, what you're going to focus on. And so my message is always, this is a health system problem. All this has to come top down. There has to be funding and resourcing. And we've talked about that today. But while the health system is trying to get fixed or figured out, there's stuff you can do for yourself, right? Like, there's stuff you can do in your little circle to help mitigate that while everything else is working out. And some of that is using your EMR and this education piece. But then there's this whole thing, and it's a term that's coming out called digital hygiene or digital wellness, right? And so I've kind of developed my 5 B's of digital wellness, kind of based on learnings from a number of great researchers in the field. But it really comes down to, when you use digital tech, you need to kind of look at these 5 B's. So the first thing is boundaries, right? So you set clear guidelines for how you're going to use it with your patients and how your clinic uses it overall, right? So staff need to know your boundaries. They need to know. So if you have a patient portal for secure messaging from patients, you need to set your guidelines, your boundaries. You need to put that in place. You have to send it out to your patients before they even start using the technology. And your staff needs to know where your boundaries are. And you need to say, I'm not going to do A, B, and C, but I will do D. And set very clear. Because a
You don't
lot of this
want
burnout is what it fuzzes,
this
right? Like,
high-tech patient support turning into intrusive wear that's just bugging you all
exactly.
day. Yeah.
Exactly. And all of a sudden you're getting all those messages directly in your inbox because you didn't set up a boundary or looked into the technology to make sure that your staff would have to deal with it, right? Yeah. So my second one is bucket filling, right? We all go into medicine for different things, but honestly, I think the majority of us go into medicine for that patient care, right? And that's where my bucket gets filled, is that interaction, that talking, like talking about their dog even, right? Like that's the piece where I kind of leave going, okay, I really have a good handle on who you are, what your problem is. And so I need to find technology that allows me to fill my bucket. So that's why AI is great, because now I don't have to sit in front of a computer typing and writing. I can actually eye contact and talk to you, right? So that fills my bucket, makes me feel better. Patients are happy. Breaks. You need to schedule breaks, right? And what I mean by breaks is breaks from your technology. So just because you have 24/7 access to your EMR, or you have an app that allows you to look at it all the time, doesn't mean you should. So it's about setting a break and saying, I'm shutting down everything and I'm going to do something else. Like, that's it. Because we don't do that. And, the whole day goes by. Most of us haven't peed or gone to the washroom or had lunch. And we've been sitting in front of an EMR the entire time. And that's going to affect us, right? So you need to set breaks where you just shut it down and you just walk away, right? Building capacity. So I think that I'm on my fourth B, building capacity. So this is about the training, right? It's finding capacity in your technology, optimizing your EMR, your workflow, design your room efficiently, right? Like a lot of times what we've done is we have a room that was set up for in-person visits and we just thrown technology in there. And now the screen is blocking the patient. Your back is to them. You don't have a good light for virtual visits. They're looking up your nose. Like you need to design your room properly to optimize that and use your tools more efficiently. And my last one is balance. Is that work-life balance? But I'm not saying go do yoga. This is like realistic expectations of what the doctors and you're going to do in your clinic. So if you have a group of 7, you come together and you say, when I'm on vacation, I'm on vacation. We're going to cover each other. I'm not checking my labs, right? But you decide that as a group because that gives you work-life balance. Because if you have 2 docs who are checking all the time and you have 3 docs who don't at all, it's going to create tension. And pretty soon those 3 docs are going to start checking their labs, right? So you need to come together and say, what's realistic? I'm not checking my labs on the weekend, right? There's probably docs out there like, what do you mean you're not going to check labs on the weekend? I was on paper charts forever with a fax machine and no one checked labs on the weekend, right? And I would like to think that none of my patients had any adverse problems because of that, because they ended up in the emerge because they went to the emerge, right? So I'm being tongue in cheek, but you got to set those for yourself. Otherwise, you're just going to burn out, right? Minimum day off a week from charts. Like, do not touch your EMR for a minimum of a day off work because you need to kind of get away from that, right? So I think it's about setting limitations, but you do it as a group with your staff so they don't even bug you. So you're not put in a position where you have to turn someone down because this is the boundary, this is the rule, and this is what we've decided. So it's kind of looking at it at that point from a digital wellness point of view.
And then, so how does OMD help the clinics and the physicians, focus on these 5 Bs? Are you guys putting out resources to help like do an inventory and a
Yeah.
self-assessment of, are you checking these criteria, or are you perhaps sliding on one of them?
Yeah, not yet. So this is kind of a new piece that we're working on. That the burnout's not new, but this digital wellness piece. So it's not actually in our one-to-ones yet. Right now, it's more just kind of in talks. It's just kind of getting it out there. Kind of, while you're talking about digital health, don't forget to look after yourself kind of piece. But I think in time, I would like that to be part of the teaching. But honestly, it's hard, Jordan, because docs are hard. Like if you come into a clinic and you have an hour and you want to maximize your EMR, you don't want to really hear about boundaries and bucket filling and breaks, right? Like I think the digital wellness piece has a place for it. And you have to kind of know, you have to be in the mindset to hear it, right? Like, because if you're overwhelmed in your clinic, it doesn't matter if I tell you to build capacity. You're going to just slam the door in my face because I would too. I would slam the door in your face. But if I'm at a conference and I've dedicated that time to wellness, or I'm so burnt out that I had to take time off and now I'm looking for resources, you're in a mindset now to understand it and you're probably going to listen to it a bit more, right? So I kind of feel like it's more giving the information you need when you're ready to hear the information for anything we talked about today.
Yeah, yeah. So it's sort of up to the docs to like try and keep that open mind, right? It's like how we talk
Yeah,
to our patients about drinking enough water and getting their
that's it.
steps and doing their exercise and all these things, but they're like,
Uh,
okay, sure, yes. You got to be putting yourself in that position to
yeah.
do these basic things.
Yeah. Maybe you make one of these your QIs, right? Like maybe your QI is setting boundaries so that your patients are happier overall, right? So it's not something that you have to do all at once. It's just kind of just pick one, schedule a break. Every hour you have an alarm go off and go outside and take a couple of breaths of fresh air and then come back inside again. Like just pick something, right? But I just want to say it's not about yoga. It's not about like, finding time for yourself or exercising more. Like this is really about like stepping away from your EMR, stepping away from your app and just getting that break. Like, cause otherwise you're not as efficient.
Well, the five B's framework makes total sense. I hope to see more of it in the future. I guess, just wrapping up on our time today.
Yeah.
Anything else you wanted to shout out before we close off?
No, I feel like, you know what? I feel like we've covered everything. I think my key messages are technology is just a tool. So it really, you have to figure out your needs and what you want solved, and then you find the right solution for that. And technology might be the right solution, but it may not be. AI is not going to solve your problems. So, because it's just a tool. But right now, I think that's where like, I'm super excited about AI. I have to tell you. But we need to look at regulations, and we need to kind of have an evaluation framework. And then the other thing is advocating for the resources you need for what's important, right? So if what's important is building capacity and education and kind of understanding these technology better and having someone even rank it for you, like we don't do that. But if that's important to you, where here's 6 options, can you tell me which is the best? Well, if that's what you want, then that's what you advocate for funding in your region or provincially and whatnot. Like, so it has to kind of come down to your needs.
And then we ask everyone at the end of the podcast, what is your number one wellness tip? I feel like I have a
Oh my
good
gosh.
idea now that we've finished the conversation, but what would your top tip be there?
So my top tip is to shut down all your technology and walk away. Um, because I think it's really important to get a real break. So I don't know if you know Dr. Mamta Gautam. So she's in Ottawa, but she is like a guru for burnout and talking about ways to combat that and wellness. And she has this tip called the Tarzan. So basically what it is when you're on vacation, you need to know when your next vacation is before that vacation ends. So it's like Tarzan, you're going from vacation or break to break. So I kind of say it's the same thing with digital wellness. So when you're on vacation, and I know people have already shut me off by now because they're like, there's no way I'm going on vacation and not looking at my EMR. But when you're on vacation, you need to be on vacation, because if you're truly not on vacation, it's just going to build up and build up. And you think that that 1 hour that you do every day is going to save you all that time later, but map it out. Take time and see, does it really save you time? Because if it doesn't, then don't do that 1 hour, right? Like, it's kind of look down the street a bit.
You got to take some time to decompress. Absolutely.
You have to take time to decompress.
Awesome. Well, Dr.
Yeah.
Chandrasena, thank you so much for joining us today. Really appreciate the insights.
Thank you. Thank you so much for having me. It's been a great conversation.